Good afternoon and welcome to today's webinar, Important Aspects of Post-Venous Treatment. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will be monitoring questions throughout the presentation and will try to answer as many of them as possible during the Q&A period. Also on the left side of your screen is the Resources tab. Click on this tab for links to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during the course of this webinar, you may click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the SVU CME credit, you must be registered, logged into this webinar, then complete the survey. The survey will open automatically at the conclusion of the live session and be available from the IAC Pro Libraries website for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. Webinar is a joint presentation of IAC and the American College of Phlebology. And now I would like to introduce today's guest speaker, Dr. Mark Meissner. Dr. Meissner is Professor of Surgery at the University of Washington School of Medicine. In addition to being an IAC Vein Center board member, he is a past president of the American Venous Forum and a member of the Society for Vascular Surgery, the American College of Surgeons, and the American College of Phlebology. Dr. Meissner's clinical interests are acute deep venous thrombosis, chronic venous disease, and the management of pelvic venous reflux. With that said, I will now turn the webinar over to today's speaker, Dr. Meissner. Dr. Meissner?
Thank you, Kelly. Good morning or good afternoon, wherever people are calling in from, and thank you for joining us. My presentation will probably take 15 to 20 minutes, and then we'll have time for questions afterwards. So with that, we'll move right along to it. I have no conflicts of interest relative to this presentation. As everyone on the call, I'm sure, knows, percutaneous ablation of the great saphenous vein, initially with either radiofrequency or laser energy, and more recently with some mechanical and chemical modes, has not only become a widely accepted alternative to saphenous vein stripping, it really has replaced it in most parts of the United States. Initial success rates of 95% have been standardly reported and have been associated with excellent patient acceptance. Most series have documented less postoperative pain, more rapid recovery and return to both work and usual activities, as well as an improved quality of life. And despite the fact that this is now one of the most widely performed procedures that all of us do, I think a lot of it remains without a lot of evidence base to back it up. And most of my talk is going to challenge, I think, some of the conventional wisdom about how we take care of patients postoperatively. Somebody once told me that there's only 3 reasons surgeons ever do anything, and that's because we always do it that way, we never do it that way, or it seemed like a good idea at the time. And I think a lot of the postoperative care that we provide these patients falls into the category of we always do it that way and always have it done that way without a lot of evidence to back it up. And hopefully this presentation will maybe not change the way you practice, but at least understand that sometimes we do things just because they seem right rather than they're supported by a lot of evidence. So I'm really going to address 3 questions about the postoperative care of patients after venous ablation of any type. First, is compression really necessary after them? Is follow-up ultrasound necessary, and what do you see when you see something? And what is the risk of recurrence following these procedures now that we have about a decade and a half experience with them? So first, let's talk about whether compression is necessary after endovenous ablation. And we'll start with the data from years ago with stripping and sort of addressed the question as whether compression really helped in the days when we used to do stripping. And probably the best study on that is this particular study that randomized 104 patients after pin stripping to either elastic bandages for 3 days or a similar course of elastic bandages, then continued compression stockings for 4 weeks after that. And as you can see in the table, at the follow-up of 1 month, there was no difference in limb volume measured volumetrically, and there was no significant difference in pain measured at either 2 weeks or 4 weeks, although surprisingly, patients who were only treated with only 3 days returned to work an average of 4 days faster than those that wore stockings for 4 days. And, there's no real explanation provided that, whether it's the psychologic disability of having to continue wearing stockings or whatever. There wasn't a lot of benefit with stripping with wearing bandages beyond 3 days. Well, now in the modern era, what data do we have about thermal ablation? And we have similar trials looking at thermal ablation, some of which we performed at the University of Washington that I'm not going to go through. This is one of the larger series that randomized 93 patients after endovenous ablation, laser ablation alone with no phlebectomies, and they either wore stockings for 48 hours or for 7 days. And this is one of the important points, is virtually every series that's ever been done really reports that there's no difference in efficacy of the procedure regardless of the duration of compression. This particular study showed 100% great saphenous vein occlusion at 3 months in both groups. Our own data is a little bit lower, but shows it's equivalent regardless of the type of compression. However, looking at quality of life, and quality of life is important in these patients, that's why most of them are being operated on, physical functioning was significantly different at 7 days. That is, that those who wore their stockings for 7 days had a higher level of physical functioning. And if you look at the table at the bottom, at 48 hours, when both groups had stockings on, there was no difference in pain. But at 1 week, the group that wore their stockings for 7 days had less postoperative pain, and not surprisingly, by 6 weeks, there was no difference. So if we look at what is the role of compression after thermal ablation, it really doesn't make any difference as far as the clinical efficacy of the procedure goes. It doesn't seem to make a big difference as far as morbidity or complications after the procedure goes, but it does seem to have a quality of life benefit afterwards. So how do we rationally approach this in patients undergoing endovenous ablation? And I personally think that we need to, based on the data, consider compression for at least 48 hours. And after that point, I think we should have an honest discussion with the patient, balancing the inconvenience of the stockings versus the likely benefits in pain and physical functioning if the patient continues to wear their stocking for about 7 days. So the take-home message is compression is probably not necessary for efficacy of the procedure, but if the patient can tolerate the stockings for 7 days, there likely are some benefits in pain, physical functioning, and our own data suggests return to more vigorous activities earlier if they wear good compression. So next I'm going to move along to screening, particularly for saphenofemoral junction thrombus extension after endovenous ablation of any type, whether it be thermal ablation or chemical ablation. It's become part of our standard practice to screen these patients early after the procedure for thrombus extension, particularly at the saphenofemoral junction. And I think this has largely been historically guided by the fact that this was an ultrasound-guided procedure. All of us have ultrasound in clinic, and it's very easy to do. And we all think we understand the benefits of screening, but I'm going to call a little bit of attention to the harms of doing it as well. So Lowell Kabnick was the first to sort of codify and name saphenofemoral thrombus extension as endovenous heat-induced thrombosis, or EHIT. And Dr. Kabnick originally classified this into 4 groups, EHIT 1 being thrombosis, flush thrombosis to the junction of the great saphenous vein and the common femoral vein, EHIT 2 being extension into the deep system, compromising less than 50% of the cross-sectional area of the lumen, EHIT 3 being a compromise of greater than 50% of the cross-sectional area, and EHIT 4 being total occlusion of the deep vein. And if we look at historically some of the very early series on this, there was indeed a significant risk of saphenofemoral thrombus extension. In the early series, this was about 7.7%, but if we go back and look at it, a lot of this was driven by Hingorani's initial experience, which I think everybody understands there were some technical issues in the early experience with radiofrequency, at least in this particular center, reporting an incidence of about 16%. If we move on to the modern era, here, with much more robust data, we can see that the EHIT is really substantially less common than was reported in the early series. This is a very robust series. There was a meta-analysis of trials that had greater than 150 patients, so there's no small case series in this. All of these had routine follow-up within 7 days of the procedure, and this included almost 14,000 patients. And you can see the results for radiofrequency and laser are approximately similar, a risk of deep venous thrombosis of about 0.2%, pulmonary embolism about 0.1%, and EHIT somewhere between 0.5% and 0.8%, with a median number of about 0.1%. So I think that's the figure to take away from this in modern robust series looking at it. So not only is this reasonably uncommon and much less common than it was in the early series, the natural history of these is substantially different than deep venous thrombosis in general. And if we look back to this first series from Hingorani, they originally described a very high incidence of this. They had a total of 73 patients. The catheter was positioned approximately 1 centimeter below the saphenofemoral junction tributaries. I think most of us start our ablations lower than that now. And all of them had follow-up ultrasound. And they reported a very high incidence of thrombosis of 16%. All except one were these saphenofemoral thrombus extensions. All of them were treated with anticoagulation, and all of them had follow-up with ultrasound within 14 days. And you can see there was very rapid resolution of these saphenofemoral thrombus extensions. Only one remained persistent at this 3 to 14-day interval. This is obviously substantially different from the natural history of deep venous thrombosis. Now, I'm going to show you some data in a minute that is going to suggest these really aren't deep venous thromboses at all. And this data comes largely from the Varithena trials, and I think BTG deserves a lot of credit for really thoroughly studying, much more thoroughly than either laser or radiofrequency ablation, the incidence of these phenomenon after endovenous ablation. This shows the thrombotic outcome of all of the Verisolve trials, or the Varithena trials, including almost 2,000 patients and about 2,500 treatment sessions. And you can see the incidence of SFJ thrombus extension is about 2% in all of these trials. And I think if you look at these closely, they divided these into saphenofemoral thrombus extension, deep venous thrombosis of the main axial veins proximally, and then muscular calf vein thrombosis. All three of these patterns are consistent with extended vascular injury, not generalized activation of coagulation. The saphenofemoral thrombus extension from injury proximally, deep venous thrombosis and muscular calf vein thrombosis, usually from propagation through perforating veins. If you looked at all the ultrasound images, and I did look at all of the ultrasound images in these trials in the phase 3 clinical program, almost all of the deep venous thrombosis are consistent with propagation through a perforator. Now, the next slide is kind of busy, but it's very interesting. This slide, and don't pay a lot of attention to all the numbers, but it involves, it separates these into proximal and distal thrombus and either symptomatic or asymptomatic. The important thing I want you to pay attention to is the ways these were treated. If you look at the bottom number, approximately equal numbers of patients were treated with either observation alone, short-term or long-term anticoagulation, or aspirin. Many of these modalities were sort of in accordance with established guidelines, but many more were not. There's really no evidence base for treating any of these thrombus with nonsteroidals other than from a symptomatic basis. And I think the important thing is, regardless of how you treated these, whether you watched them alone, whether you treated them for 1 or 2 weeks, whether you treated them in the long term, in this whole trial, there was not a single pulmonary embolism, and there was not a single symptomatic recurrent venous thromboembolism. So these things were very benign, regardless of how they were treated within the trial. I'm going to show you some data here now from the trial. This hasn't been published before, although it's been presented to suggest that these, in fact, aren't really deep venous thrombosis. The subset of the patients in the Varithena trial had D-dimer measurements determined at 1 week to measure the degree of activated coagulation. Patients who didn't develop a VTE are shown in the yellow triangles, and those that did in the red squares, the green triangles, and the white circles depending on which particular trial there was, and you can see there's virtually no difference in activated coagulation between those patients who developed the venous thromboembolism and those who didn't. And if you look at the levels, the D-dimer levels are very low. In the vast majority of patients, they're less than 100 micrograms per mil, or 1 microgram per mil. Now, I'm going to show you what activated coagulation really looks like, and in this one, it's going to be nanograms per mil, not micrograms. We did a trial several years ago looking at severely injured patients who came in without a deep venous thrombosis. All of them had standardized prophylaxis, and there was a cumulative DVT incidence in these severely injured trauma patients of 60% at 30 days. And if you look at the D-dimer levels, all of these are at least 4 to hundreds of fold times higher than in the patients who were treated with sclerosants. This is what activated coagulation looks like, not what we saw in the Verisolve trial. And I think it goes back to the fact that deep venous thrombosis is not really a disease of the veins. It's a coagulation disorder that's localized in areas of stasis, particularly in the leg veins. And, what we saw in the Varithena trial suggests that there's not activation of coagulation as we would expect in a usual deep venous thrombosis. So I'm going to get back to the issue of screening, and I think I have to admit we do screen patients just because we have the ultrasound in clinic, but I think it's important to recognize the fallacy of screening. If we take any test, doesn't matter whether it's ultrasound or anything else, with a 95% positive and negative predictive value, as ultrasound has, and look at how the positive and negative predictive value are really dependent on the pretest probability of deep venous thrombosis. If we're looking at patients walking in with calf pain just off the street, the incidence of DVT in the properly selected population will be about 25% or so, and you can see both the positive and negative predictive value are reasonable in patients with a pretest probability of disease of about 25%. When we get down to talking to EHIT, again, we're talking at an incidence of EHIT of less than 1%, and we're operating down in this area of the curve where the positive and negative predictive values of ultrasound are really very low. And what I'm getting at is some of the harms of screening. And if we just do the simple math on it and take the baseline assumption that after venous ablation there's a DVT incidence at the high side of 2%, that is more likely in the sclerotherapy trials, and that the incidence of pulmonary embolism, again, in the meta-analysis, this was about 0.1%, but if we consider it goes somewhere between the reported incidence of 0.04% and 1%, and that the predictive value of ultrasound at a pretest probability of 0.02, we get a negative predictive value of 1. It's very accurate if it's not there, but the positive predictive value of ultrasound at this low incidence is only about 0.25%, and we're going to compare that to a bleeding risk of low molecular weight heparin at 90 days of 2.5%. And I know some people are going to say, well, we wouldn't treat somebody for 90 days. I just chose this 2.5% because it's really the only figure that's out there in the literature. You can modify that accordingly, but these are just the baseline assumptions. And then we look at 10,000 patients undergoing great saphenous vein ablation. At that incidence of deep venous thrombosis, that's going to give us 200 positive ultrasound scans. At a pretest probability of 0.02, 50 of those are going to be true positives and 150 are going to be false positives. If we anticoagulate everybody with a positive scan, we're going to prevent about 4 pulmonary embolisms, so the number needed to treat is about 2,600. If we look at those patients who had false positive scans and anticoagulate all of those, we're going to cause about 4 bleeding episodes, exactly equivalent to the number of pulmonary emboli presented, with the number needed to harm that's virtually identical of 2,600. So I think it's fine to screen as we do, but I think we have to understand that screening is associated with some harms as well as benefits. So what if you find something? When do you treat? And there's a bunch of recommendations in the literature, none of which are really supported by any evidence at all. In 2012, Dr. Kabnick's group proposed this algorithm where EHIT2 was treated with low molecular weight heparin, EHIT3 and 4 with low molecular weight heparin, possibly followed by Coumadin. That's a little bit different than this scenario proposed by Peter Lawrence and his group at UCLA. They divide the saphenofemoral thrombus extension into 6 levels, not 4 as Dr. Kabnick did, and they suggest that when you have flush occlusion, It's the surgeon's choice is what to do. Once you get any extension into the common femoral vein, low molecular weight heparin, and if it's an occlusive thrombus, low molecular weight heparin plus warfarin. But I think we have to understand that virtually all of these recommendations are based on what I do seems to work, without a lot of suggestion of what the harms of therapy, including the inconvenience to the patient of doing this. There's virtually no evidence-based algorithms, and so I think a lot of us are sort of stuck on our own deciding what to do with these. And I think some of the recommendations, although they're out there, I think we have to understand that there's really no evidence supporting them, and all of them, at least in my mind, seem to suggest that these things are of more consequence than probably they are. I think most people would agree that EHIT 1 and most EHIT 2s require no treatment. EHIT 3 is where we have to start to worry, and there's virtually no data to guide what we do with those. I know personally in my practice, I base it both on what the thrombus appears to look like. Is it adherent? Is it free-floating? As well as the patient's risk factors with a history of previous DVT or any hypercoagulability. And EHIT 4, I think most people have virtually never seen an EHIT 4. If you have an occlusive thrombus, it certainly should be symptomatic and shouldn't be discovered just on ultrasound. And clearly, that degree of thrombosis clearly warrants treatment. So in conclusion, at least regarding thrombosis after endovenous ablation, in modern large series, the incidence is very low, with an incidence of EHIT of somewhere between 0.5 and 0.8% for thermal ablation and about 2% for foam sclerotherapy. This has few characteristics of a real deep venous thrombosis, and for those of you who did pathology in medical schools, I'm sure everyone did, these are probably really clots, not thrombosis. They're not something formed by activated coagulation in flowing blood. What's not characteristic of them is they have rapid resolution. PE is very rare. There's no evidence of activated coagulation, and the outcomes do seem to be relatively independent of how you treat them. And I think it's fine to screen, but we do have to understand the risk versus the harm and the absence of data to really support it, and the fact that there are really no validated treatment outcomes whatsoever. And so now we're going to move on to the next and last question, the risk of recurrence after endovenous ablation. And I'm going to again start with the stripping data, which I think over the last century has really been the gold standard, and we have to, I think, look at what that data says and to know how to compare it to endovenous ablation. This was a long-term follow-up up to 11 years of a series of patients. They were randomized either to high ligation and stripping or high ligation alone. And at 11 years of follow-up, 86% of those patients undergoing high ligation and stripping were free of any recurrence, in comparison to only 70% of those undergoing high ligation without stripping. And the factors associated with reintervention were neovascularization at the saphenofemoral junction, an incompetent thigh perforating vein, or, importantly, from the standpoint of thermal ablation, was an incompetent saphenofemoral junction, which was associated with about a 5-fold increased risk of recurrent deep venous thrombosis. So now moving to the modern era, probably the most robust data comes from a systematic review and meta-analysis that was commissioned by the Society for Vascular Surgery and American Venous Forum, and this was just combined to comparative trials. That is, there were no case series in this study. All of them were series that compared surgery to radiofrequency ablation, laser ablation, or sclerotherapy, and it included almost 10,000 patients. And the conclusions were sclerotherapy clearly was associated with an increase of recurrence, about double that of any of the other technologies. For laser ablation versus surgery, there was clearly an early benefit, as we all know, in quality of life, but no late difference. Unfortunately, most of the data for laser ablation was not good enough to really do a good meta-analysis of recurrence, but it was for radiofrequency ablation, which clearly showed that there was no difference in the risk of recurrence with either radiofrequency ablation or surgery, with a relative risk of over 0.9. And at the time of this review, back in 2012, there were no direct comparisons of laser and radiofrequency ablation. So let's look at the mechanisms of recurrence, particularly in this series after radiofrequency ablation. This is probably the largest and best series that's been done looking at recurrence after radiofrequency ablation that was published by Rob Merchant. This is a good series. It does have some statistical problems with it. Most notably, they use no actuarial analysis or life tables to really account for dropouts or anything else. And it's important to note that the vast majority of the limbs did not complete 5 years of follow-up. But in these 1,200 patients, they had anatomic failures in 185 limbs, that is ultrasound-defined failures, and recurrent varicose veins in about 27% at 5 years. I think most importantly is to look at the patterns of recurrence that this series laid out. The first is type 1, which was just a failure. Oops, I'm sorry, my slides changed there. A failure of the ablation in the first point, and this really wasn't associated with an increased risk of recurrence. Type 2 represents recanalization of at least a portion of the occluded great saphenous vein in panel B, showing proximally, and in panel C, recanalization in the mid portion of the great saphenous vein with reflux in and out of tributaries. This was the most common type of recurrence and was associated with about a 4-fold increased risk of recurrent varicose veins. And type 3 was recurrent groin reflux in a pattern that we're all familiar with recurrent varicosities either in the anterior or posterior accessory saphenous vein, and it was about a 4-fold increased risk of recurrent varicose veins. So what does this look like clinically? And we can get some data from this from a couple of randomized clinical trials that have been performed. The first one randomized about 400 patients to either endovenous ablation or high ligation and stripping, and had about 2.5 years of follow-up, not long-term, but sort of mid-term follow-up. As all of us know, there was a better cosmetic outcome with endovenous laser ablation, but there was no difference in quality of life at 24 months between the two. If we look at freedom from saphenofemoral junction reflux in these two groups of patients, endovenous ablation was associated with more reflux at 2.5 years than was high ligation and stripping. But there was no difference in the freedom from clinical recurrence, that is the development of recurrent varicose veins between high ligation and stripping at about 2 years. So take home from this is fairly equivalent, even though there was more groin reflux in those that underwent endovenous laser ablation. There was really no difference in clinical occurrence and development of recurrent varicose veins out to 2 years. We see sort of the same thing at 5 years. So this is a little bit different study. This had split leg randomization. That is, all patients had bilateral C2 disease. One leg got endovenous laser ablation without saphenofemoral ligation. The other got endovenous ablation with saphenofemoral ligation, and all patients who had residual varices had sclerotherapy at 6 weeks. And you can see between these two, whether you did high ligation or not, there's no difference in groin recurrence at 5 years of follow-up. There's a little bit of numerical difference between them, but statistically this wasn't significant. The important thing is the mechanisms of recurrence, and these were very different whether patients had high ligation or no high ligation. If patients had high ligation, about a third of these recurrence were due to neovascularization in the groin, which was the most common cause, while without high ligation, they were more commonly due to either saphenous vein recanalization or incompetent tributaries at the groin. So the takeaway from this really is that there's no difference in clinical recurrence whether you ligate the saphenofemoral junction or not, although the modes of recurrence are going to be different. So in conclusion, what we've covered in the last 20 minutes or so is that compression likely has no effect on efficacy or morbidity, although it clearly does have some effect on pain and physical functioning after endovenous ablation. Saphenofemoral thrombus extension, the bulk of the data suggests that this is likely a little clinical consequence, and that we need to understand that screening also has harms as well as benefits. And finally, as far as recurrence goes, in comparison to high ligation and stripping, the rates of recurrence are similar, but the mechanisms are different. And with that, I'll turn it back over to Kelly and Marge for any questions.
Okay, thank you, Doctor. And at this time, we will begin the Q&A session. We would ask that all of your questions be relevant to the information in today's webinar. Questions about accreditation should be directed to IAC by phone or email following the webinar. From IAC Vascular Testing and Vein Center, I'd like to introduce Marge Hutchison, IAC Director of Accreditation, and Laura Henson, our clinical specialist. Marge and Laura will be assisting with the Q&A session today. Marge, would you like to start us off?
Yes, thanks, Kelly. Thanks, Dr. Meissner. Very, very good information. A couple of questions to begin with. So, in your experience, is this EHIT a symptomatic problem?
I think in most people's experience, it is not a symptomatic problem. In fact, I teach our residents that this, in fact, is what I call patients who have EHIT are victims of medical imaging technology. The short acronym for that is VOMIT. So most of these are not symptomatic. They're just identified because we do the procedures under ultrasound and we screen the patients afterwards under ultrasound.
All right. The second question relates to the same thing to EHIT. It sounds as though to call an EHIT post-procedure a DVT is not accurate. So what are we going to call it?
In my opinion, I'm not quite sure I have a better name for it. I do have a number of acronyms that I use for it that I probably can't say in public. But this clearly, to me, the way I understand deep venous thrombosis is deep venous thrombosis is really a disease of coagulation that's localized to the legs, largely by stasis and things. Clearly, this phenomenon of the saphenofemoral thrombus extension is not associated with activated coagulation. It's either a physical injury to the vein, either by chemicals in the case of sclerotherapy or by heat in the case of endothermal venous ablation, with localized activation of coagulation right at the site of injury, but not systemic activation of coagulation. Whether it's appropriate to treat those with anticoagulants or not, just from a theoretical perspective, if you have no activated coagulation, why do you need an anticoagulant? But understanding that some patients may have an occlusive or significant thrombus there that may need anticoagulation, my preferred term for it is just saphenofemoral thrombus extension. And the saphenofemoral is right and the extension is right. The question is really whether you should call this a thrombus or not. In the absence of a better word, I would probably call it saphenofemoral thrombus extension.
Okay. Now, have you any experience with EHIT becoming pulmonary embolism?
In 16 years, I've had one patient who did develop a symptomatic pulmonary embolism at home 3 days after the procedure. She did have some mild chest pain and shortness of breath. She failed to go to the doctor for almost a week afterwards. So I have seen one patient with a symptomatic pulmonary embolism. And clearly it does occur, but if you look at the large data sets, including almost 10,000 patients, the incidence of it is about 0.1%.
All right. Another question related to EHIT. You mentioned Dr. Kabnick's 4 categories and Dr. Lawrence's 6 categories. What's the best way to go?
Well, I think just because it's most established in the literature and is fairly easy to determine with ultrasound, I personally favor Dr. Kabnick's categorization of it. I think this is an area, though, that really needs some standardization, and I think it's fortunate the American Venous Forum is going to develop some practice guidelines around this. Unfortunately, the bad part about practice guidelines around this is there's really no data to guide those practice guidelines, so they're really going to end up being consensus opinion rather than based upon any data about it.
Okay.
But we can look forward to those.
Okay. And then regarding the post-procedure ultrasound, a lot of times that appointment in and of itself becomes the follow-up to the procedure. If we don't do the ultrasound, when should the patient follow up with the physician?
Well, I think that depends a little bit on what you're doing. I personally do phlebectomy on every patient. Well, not every patient, but patients who are going to have a concurrent management of their tributaries. I do phlebectomy simultaneously. So I like to see them at a week just for a wound check and to see how they're doing. And my practice is to do point-of-care bedside ultrasound at that time, just because that's become the de facto standard of care, and so I do feel that we continue to do it, although I recognize that the value of it is probably very limited. So in my practice, I see patients at a week. If you're not doing concurrent phlebectomy, I think anywhere, whatever your personal experience is on it, I personally would feel comfortable seeing them out to 2 weeks or so if we weren't doing concurrent phlebectomy.
Okay, now we're going to move on a little bit. So when you talked about post-procedure compression, whether it be for a few days or 7 days, are you talking that they should wear the hose 24/7 or just during the day and off at night?
That's a good question, and I can't tell you that there's any data regarding that. I think some of that also depends on whether you're doing ablation alone or in combination with phlebectomy. And I'll address the latter first. If you're doing it in combination with phlebectomy, those patients do have very small but open wounds, and so in that case, I do like to have them wear their bandage, and my practice is 72 hours around the clock. And then after that, I go with the recommendations I said. We talk to the patient about the fact that they're likely going to be more comfortable if they wear their stockings, but it's a little bit up to them. If they're too troublesome and too much of an inconvenience the patient to put on, I tell them the results are going to be the same. They may be a little bit more uncomfortable, and it's really their choice. So the second scenario is in the case of endovenous ablation without concurrent management of the tributaries, and I think there we go back to the fact that probably compression doesn't add a lot to the efficacy of the therapy, although there's really no data on what happens if you compress patients less than 48 hours. Probably it doesn't add a lot to the efficacy of the procedure, and if the patient is more comfortable taking them off at night, I would not see a problem with doing that.
I would wager, just from a personal perspective, that patients would much rather take them off than leave them on.
I will tell you, I have the discussion with every patient, both in clinic and at the time of the procedure, about what the data says about compression, that there's no difference in efficacy. They will be more comfortable, and they will return to activities faster if they wear compression for 7 days. And I will tell you, the majority of patients choose not to wear compression.
Yeah. Okay, what is the reason for the large difference between the initial E-hit of 7.7% to the current outcome of 0.5%? What changed?
You know, I think probably the single most important thing that's changed is moving the catheter farther from the saphenofemoral junction. And I think when the Anil Hingorani's initial data was initially presented, I think there was uniform consensus that they had the catheter too close to the saphenofemoral junction. So that's probably the most important thing. I think there have been other changes as well. I think in the early days, a lot of these were done under general anesthesia with the patient asleep. I think local anesthesia and having the patient up and walking faster also helps. How much of it is due to that versus just understanding technically that you do have some forward heat transfer with the procedure, it's hard to know.
Mm-hmm. I recently spoke with Dr. Kabnick about this, and he recommends 2.5 centimeters. Is that your recommendation as well, pullback?
That is my recommendation, but my recommendation, that's what I do, and my recommendation is based on Dr. Kabnick's recommendation. Okay,
good. All right. What are the differences in the ultrasound characteristics of a GSV post-ablation thrombus and a routine thrombophlebitis? How do you tell the difference?
Well, clinically, I'm not sure you can, and that both of them are driven by inflammation. It's interesting, and that's I didn't get into it much in my talk. If you go back to the old pathology books, there is a difference between thrombosis and clot. Even though we often talk about deep venous thrombosis being clot, pathologically, they're not the same thing at all. By definition, a thrombus is formed by activated coagulation in a living patient in actively flowing blood. And if you remember from your pathology, what you see are the classical lines of Zahn within the thrombus. That is, you see laminations of thrombus with these lines of Zahns between it. In contrast, clot is either formed in a dead patient or in non-flowing blood without activated coagulation. And what we see, that's the stuff that after a severe injury or a trauma, that's the stuff you scoop out of the abdomen that's not formed in flowing blood, and it's amorphous material that doesn't have these lines as on and some of the other pathological characteristics. So by definition, if you have a true thrombus, you should see all of the pathological findings of thrombus, while a clot will just be this amorphous mixture of red cells, fibrin, and platelets. From a clinical perspective, both of those are going to recruit white cells into the thrombus and into the vein wall and cause inflammation, and clinically they should appear the same.
Oh, okay. I think you may have already addressed this. What's your personal post-procedure compression therapy post-ablation?
The personal one I like the best. We did a trial that was presented in a poster at the ACP last year, looking at a specifically designed stocking that had 8 millimeters of compression at the thigh, and then it had a thigh cuff adding another 18 to 20 millimeters around the thigh. And in the trial that we did, which was a randomized trial between standard 20 to 30 millimeter thigh high compression stockings and this specialized compression, patients were more comfortable and returned to vigorous activity like sports, running that sooner with this specialized compression. The bad part is that product has never been commercialized and is not available. So I do believe compression does help pain afterwards, and my personal protocol in not having these specialized stockings available anymore is a thigh-high 20 to 30 millimeter stocking, and have the patient wear it around the clock for 3 days. And again, not because there's data that 3 days is necessary. It's just because all of the studies have looked at 48 to 72 hours of compression. So I have everybody wear it for 72 hours around the clock. And again, the around the clock is largely because I'm doing concurrent phlebectomy with it. And then have the discussion at least twice with the patient preoperatively that you will be more comfortable if you wear the stockings, but you need to balance the inconvenience and discomfort of putting the stockings on versus the added comfort that you might have by wearing them. And then I leave it up to the patient after 3 days.
Okay, thank you. So if you are doing a post-procedure ultrasound on the patient and you find an E-hit 1 or 2, do you bring the patient back? Do you treat them with NSAIDs, or do you just let them go on?
I treat them with an aspirin for 2 weeks, and that's all we do.
And then will you bring them back after 2 weeks of the aspirin and re-look at them, or no?
Some of that is a little bit of judgment call on what the thrombus looks like. If it's truly an E-hit 1 that is a flush saphenothermal occlusion, I never bring them back. And I should clarify that. An E-hit 1 where it's a flush occlusion, we don't even treat them with aspirin. Just send them on their way. With E-hit 2, it depends a little bit on what the thrombus looks like. A lot of times what you see, particularly with foam, is a little bit of laminated thrombus on the anterior aspect of the vein that you can imagine. That's where the foam spilled a little bit into the common femoral vein, and that's strictly a chemical injury to the vein, and usually it's a very thin laminated thrombus. If I see that, usually we'll treat them with aspirin for 2 weeks and won't see them back. Rarely, if you see an E-hit 1 extending towards an E-hit 2 that's really looks like it's floating out into the vein, those patients I will follow up again. So that's part of the area with this whole area is I do like Dr. Cabney's categorization, but particularly when you get into E-hit 2, there are E-hit 2s and there are E-hit 2s, and some of them you can look at and say very clearly, that's a localized vein injury that's not going to propagate, while others may look a little bit more worrisome.
Okay. When you're doing these post-procedure ultrasounds, how extensively do you look at the deep system of that treated leg?
I don't unless the patient is having symptoms. I do a bedside point-of-care ultrasound of the saphenofemoral junction and point check the great saphenous vein, just for my own knowledge to know that we were successful in doing it, but don't evaluate the deep system unless the patient is having symptoms from it.
Okay.
Interestingly, this was a long discussion with the FDA with the Varithena trial, and the FDA is particularly not convinced that you should screen from this. It was part of the study, but there was a little bit of reluctance on the FDA as why are you screening for these that are asymptomatic?
Huh. All right. Here's a little bit of a different question. How do you treat significant pain after foam sclerotherapy, and then they added trapped coagulum?
Well, I have to admit I don't see it a whole lot in that most of the time we do phlebectomy rather than foam. In the rare cases, which is probably less than one a month, and patients do have pain and inflammation, we will make a small incision over the just in clinic and evacuate the thrombus.
All right. Lots of questions here. I'm trying to find some really good ones here. How about if we perform a post-ultrasound and find an E-hit, would it be reasonable to recheck with ultrasound again?
Well, I think as long as you understand the data, it's always reasonable. The question is whether it's necessary or not. And I think particularly as it went over, I think E-hit 1, I don't personally check and don't think there's a reason to check. E-hit 2, if I'm comfortable that it is just a laminated thrombus on the anterior aspect of the vein that's clearly a physical injury, I won't recheck those. If I'm more concerned about the way it looks, that is, if it's free-floating or projecting out into the lumen and not just this laminated thrombus on the anterior aspect of the vein, I will recheck some of those. So some of that is dependent on your concern on the way it looks at the time.
Okay. Here's a question. We saw an isolated partial popliteal vein thrombus, about 4 centimeters long, in a patient during screening 1 week post-EVLA and hook phlebectomy. The EVLA was performed on the GSV. What do we call this? Is this a DVT?
That I would probably call a DVT, and probably it's associated with the phlebectomy rather than the thermal ablation itself. And depending on that, in that case, is probably not a direct injury to the popliteal vein, but probably from thrombus propagation through a perforator from the time of phlebectomy, and I would call that a DVT, and I would imagine that that's probably not this laminated thrombus along the wall, and probably would in fact treat that particular thrombus. It's interesting in the series from the University of Michigan that looked at particularly E-hit. The only real factors that were associated with any kind of thrombotic event afterwards, probably number one was concurrent phlebectomy, which clearly does seem to raise your incidence of thrombosis after it. And I think that's why, at least in my practice, I think it's particularly important to perform them, under local anesthesia in the clinic, not under general anesthesia, and to get the patient up and walking quickly and emphasize that to them.
Okay. Here's an interesting question regarding thrombus. If you note it to be behind one of the valves, do you take care of that any differently?
If it was just a valve pocket thrombus, I probably wouldn't. If it was projecting beyond the valve, I would worry about it. And some of it would depend a little bit on the scenario in which it arose. If it was thrombus behind a femoral valve after just a focal, very small thrombus after Saphenous ablation, I'd probably ignore it. But if it was propagating significantly beyond that, I probably would pay attention to it. And I think some of that is just a difference in practice patterns. As I mentioned, we're pretty aggressive about looking at the deep system in patients who have symptoms. Not so aggressive, in fact, not at all aggressive. We don't even look at the deep system in patients who don't have symptoms.
Okay. If a patient does have an E-hit following the procedure, but is in need for a second procedure, how long should you wait in between?
That's a good question. I think there's obviously no data to guide that. Based on what I've said in my presentation, I think E-hits are thermal injury, not activated coagulation. And activated coagulation is what I would really worry about So I probably would not change what I standardly do afterwards. My standard is I usually wait about 4 weeks till the patient's fully recovered and do it then. And again, I'm sure people's practice patterns reasonably vary around that a lot. But again, I'd go back to the fact that I don't think these phenomena are associated with activated coagulation, so I probably wouldn't modify my usual practice, but I'd probably be a little more careful in where I position the catheter tip the next time. Okay.
And then when do you have the patient return to normal activity following the procedure?
That afternoon.
Oh, good. Wow. All right. Here's a little bit more of a technical question on your end. What if the patient has a lower extremity ankle perforator with large varicose veins in mid and lower calf, reflux in the upper GSV? Post-ablation, would you do phlebectomy of the lower leg varicosities, sclerotherapy, or just do compression and follow-up?
That would depend a little bit on what the varicosities look like. Again, my go-to standard procedure is phlebectomy, and if they were typical 4 to 5 millimeter soft tissue varicosities, I would treat them with phlebectomy. There are some of the smaller ones that are immediately subdermal that phlebectomy doesn't work on, isn't as easy to do on those. I will treat with sclerotherapy. But my usual approach is I sort of like the one-stop shopping approach and take care of everything at once, both from the patient's perspective so they can get on with their lives, as well as the fact that from a resource utilization perspective, it's a lot more intensive to use the resources to bring them back and address later. So the short answer is if it was one I thought was very amenable to phlebectomy, that would be my go-to procedure, sclerotherapy, if it was immediately subdermal or I thought it was going to be a little more troublesome to phlebectomize.
Okay, and I think this will be our last question here. Is there any way to predict who is likely to get EHIT?
From the data that's out there, there is some suggestion that a previous history of deep venous thrombosis may predispose to it. That I'm not quite entirely sure about, because at least the data out there, as I showed with the Varithena data, really suggests that there isn't any further activation of coagulation with most of these procedures. But other than that, I don't think there's a lot of predictive factors for EHIT itself. Certainly if we consider the full spectrum of EHIT plus deep venous thrombosis, whether it's in a muscular calf vein or in a deep vein, phlebectomy at the time adds to the risk of that. But I don't think it contributes a lot to the risk of EHIT. All
right. Well, I want to personally thank you. I think Kelly's going to come on and give some closing remarks.
Okay. Thank you, Marge, and thanks again, everyone, and a very special thank you to our presenter today, Dr. Meissner. Feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC Pro Libraries website for 3 business days. In the upper left, you'll click on My Webinars. Look for the title of this session, Important Aspects of Post-Venous Treatment. Beneath this title, you will see the link Take Evaluation. Click this link to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through a new link on the My Webinars page called View Certificate. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you all for joining us today and appreciate your participation.